Everyone, to the first of 4 Smilow Shares events with a focus on National Cancer Survivors Day, or here at Smilow, we're going to celebrate the entire month. My name is Dr. Tara Sanft. I am the director of the Survivorship Clinic at Yale New Haven, so the chair of the NCCN Survivorship Guidelines. This is near and dear to my heart, and it's my pleasure to be facilitating this panel tonight on strength and exercise. Just a few things to mention before we get started. This is supposed to be fun and casual and hopefully interactive. In our brainstorming sessions, we decided we would come up with some myth-busting ways to talk about some of these topics, because there is certainly a lot of myths as it relates to exercise and strength after cancer. We have a lot of people tuning in tonight, so welcome. If you have questions, we encourage you to use the question and answer section, or for the chat, you can chat to the panelists if you'd like to put in your questions that way. And I know that some of my dear friends and patients are on the call tonight too. So before we get started, we'll just go around and we can briefly introduce each of our speakers and panelists tonight. Why don't we start with Kelly, and then we'll scoot around, and then we'll have Stacey kick us off with some words.
Hi, my name is Kelly Herzog. I'm an exercise physiologist at Greenwich Hospital. I've been there for 15 years, and I work with cardiac rehab, pulmonary rehab, and our Next Steps breast cancer program.
Thank you. Scott.
Hi, I'm Scott Capozza. I'm the physical therapist for the Smilow Multidisciplinary Survivorship Clinic that Dr. Sanft is the medical director of up in New Haven. And I'm also the first physical therapist at Yale New Haven Hospital who's dedicated to doing oncology rehab. So it's an honor and a pleasure to be here tonight.
And Dr. Janet Freedman.
I'm Janet Freedman, and I'm a physiatrist at Greenwich Hospital in the physical medicine department. And I treat a wide range of patients with physical medicine and rehabilitation, but also see all of our breast cancer patients and staff our new survivorship clinic.
And Stacey LaRosa.
My name is Stacey LaRosa. I'm a nurse practitioner working in the Smilow office in Waterbury. So for any of you listening in a little bit north of New Haven, but not quite as far west as Greenwich, we are a small office. It's great, easy on off from 84. So anyone, we treat every type of cancer there.
Great, thank you so much. I think what we'll do is we'll start with a few words from Stacey, and Stacey, tell us what you were thinking about when coming on to this panel tonight.
So when I was coming onto this panel, I would say one of the most common myths that I hear from patients about exercise is related to fatigue. So fatigue is obviously one of the most common symptoms that patients experience when they are going through cancer treatment. And unfortunately, even for survivors, it's one of the most common symptoms experienced even after being cured of cancer. So oftentimes we're talking about how to manage fatigue. And one of the most common things that I recommend is exercise. And the first response I get is, how can I possibly exercise? I'm exhausted enough already. That's going to make me even more exhausted. You must be crazy. So I get it. It seems totally counterintuitive that exerting yourself would actually lead to more energy, but there's actually strong evidence that it's true. So the typical dose, so to speak, for activity that's been proven to help fatigue is 30 minutes of moderate aerobic exercise 3 times per week, plus twice per week of strength exercise. You will note that this is technically different than the recommendations for exercise for general health and physical fitness, which would be about 5 times per week of moderate activity for 30 minutes each. But it can absolutely help fatigue. The few things that I tell my patients is, first of all, set an achievable goal. So for many patients going through chemotherapy, radiation, or surgery, you may have not been very physically active during that treatment. It might have been hard to get off the couch to even go to the bathroom. So setting an achievable goal of, first I'm going to go from the couch to the front door, then I'm going to go to the couch to the mailbox, setting the goal is of course 30 minutes 3 times a week, but you don't want to feel like you failed or that you haven't reached your goal by not meeting that. So keep track of that and give yourself credit. The second thing I would say is telling patients to choose an activity that you enjoy. So moderate aerobic activity would be brisk walking, tennis, biking, or dancing. So find one of those that you really enjoy and can actually see yourself doing. So for me, I hate dancing. So if anyone told me that Zumba was my only form of exercise, I would avoid it at all costs, but I love biking. And so it's something I'm actually more excited about doing. Any of you doing Closer to Free Ride also. And finally, find someone that you enjoy doing exercise with so that they can actually keep you accountable and you'll enjoy it, whether it's a spouse or another cancer survivor or a friend or family member. The important thing to remember is safety first. So always talk to your oncology provider about what the safest way you need to, if you can have clearance to exercise, if there's any restrictions that you need to follow or anything like that. And then in terms of what kind of program, I'm going to turn the floor over to Scott in terms of exactly how to start a program, what that might look like, and what options are available for you locally.
Thank you, Stacey. Those are some great myths to start with. How could I possibly exercise if I'm so fatigued? But you're right. The evidence shows that that is some of the best medicine. Janet, let's move to you. I know that you have a few slides to take us through, and you're going to bust some myths as well. And you are muted, so you might need to unmute yourself before speaking.
Okay, so I wanted to talk about the myth that exercise will cause lymphedema. And I started treating lymphedema in the late 1980s, and we had very different ideas about it at that time. So lymphedema, just to catch us all up on what it is a swelling of a part of the body, and it can occur after any type of surgery that involves the lymph nodes. So it can cause swelling in the arm, the leg, the head and neck, and the breast. And it's an accumulation of fluid in the area that is having trouble with the normal drainage it would have, because lymph nodes drain this fluid called lymph, which is about 10% of our circulating.
Just me?
Our body, so many different types of surgery and cancer treatment can affect that. And just to give you an idea of the rate of lymphedema now, if you had sentinel lymph node biopsy with breast cancer, your risk is about 2 to 5%. When I first started treating lymphedema, almost everyone had axillary lymph node dissection, which took out many more lymph nodes and had a much higher rate. Prostate cancer, uterine cancer, ovarian cancer, skin cancer, all these types of treatments can give you risk of lymphedema. Oh, and now I'm not going. Okay, just a picture of arm lymphedema. So we did a lot of fear mongering about lymphedema in the 1980s and into the 1990s. You know, we didn't really know why do 40% of people get it? Why isn't it 100%? Why is it 1%? What are the risk factors? So we came up with huge lists of things not to do because that might cause lymphedema. And I always tell patients, when you see this long a list, it means we really don't know what the cause is. We're just throwing everything here. So patients have told me, they were told, don't wear tight clothing, don't wear any elastic wrists on your blouses, don't carry a shoulder bag, don't lift over 5 pounds. And just think, a gallon of milk weighs 8 pounds. Don't fly in an airplane, don't have a blood test, don't have blood pressure, don't ever have surgery on that limb for anything else. And I've had patients who were told not to lift their grandchildren. So we really terrified people about lymphedema, thinking that these common things in life could cause it. So, oops, I want to go back for a minute. So there was a big prohibition about exercise with lymphedema, especially lifting weights, on the idea that you were going to increase blood flow to your muscles, that would make more lymph fluid, and that part of your body would just get bigger and bigger and bigger. So I was never really happy about this, because as a physiatrist working with a lot of physical problems, I knew that if you are now not going to use this arm for anything, it's going to get weaker and weaker and weaker. And then, you know, one day you're going to tear your rotator cuff because you pick something up. So I came home from work one day and there was the New England Journal of Medicine in my mailbox. And this was the days when it was always in paper. And this is like the premier medical journal in the country. And they would have their top articles on the front cover. So you could look at it and go, ooh. And here was an article and the title was Weightlifting in Women with Breast Cancer Related Lymphedema. And I was like, oh no, I've sort of been telling people they can exercise and what's going on. So this was a really great big study, 295 women who'd been treated for breast cancer. Half had lymphedema, half did not. And they did arm and leg resistance exercise. So they were weightlifting twice a week for 52 weeks, 60 to 90-minute sessions. Like this was serious stuff. They wore their compression garment if they had lymphedema. And lo and behold, after a year of weightlifting, they had no volume change. So this like freed us to now go out in the world and try to erase a lot of the fear we had put into people. Other studies came out. I'll just run through these quickly. This is a study on hatha yoga. Same thing, no yoga, no yoga. You can't do downward dog and put your arm in that dependent position and lean your body on it. That's dangerous. So again, 3 times a week, 8 weeks. And in this study, lymphedema actually improved. Another study, again, half the patients have lymphedema. This was arm and leg exercise. In this study, wearing a garment was optional and no change in limb volume. And I think this is my last one here. Again, 32 patients, all with lymphedema. This was a mixed exercise, aerobics, aquatics, and resistance. Again, no change in arm volume. So, why were we worried? We shouldn't be worried because exercise adapts muscles, it adapts the circulation system. We grow more capillaries when we exercise, so blood can go in and out, and it doesn't really change your lymph structure. What happened to your lymph system from surgery, radiation is still there. And exercise also increases what we call the muscle pump, and that directs blood out of the limb into the trunk. And as I said, we protect the limb from developing weakness and possible injury. So can you lift weights? Yes. Weight training is safe for people who've had lymph nodes removed. People with lymphedema probably should wear their garments during exercise. That's what I still tell people in general to do. But there's also no limit. You can gradually increase and your body will adapt to it. So that was what I wanted to say. Okay.
Thank you, Janet. What a great myth to bust. And I'm sure that there is more to talk about there. Everyone, if you have questions, you can put them in the chat or the Q&A. And that leads us to Scott. Talk to us a little bit about what your thoughts are on this topic tonight.
Well, first of all, both Stacey and Dr. Freedman, you set the stage perfectly, because these are some of the big myths that we see in survivorship. These are some of the big myths that I see in outpatient physical therapy. And Dr. Freedman, you're right, that study from Katie Schmitz and her team, you're right, it did kind of free us, to say that, yes, we can do this. One thing I want to make sure that we let everybody know is that, that those exercises, those were all supervised, right? They were all supervised by physical therapists. They were supervised by trained exercise physiologists who had experience working with cancer survivors. And so I think that that's one of the things that we should always, keep in the back of our mind. Especially if you're starting an exercise program and you've never exercised before, that it's probably good to seek out professional assistance when you're doing that. But yeah, when it comes to these myths of exercise and coming up with, I don't know how to exercise, I don't know what my favorite kind of exercise is. Stacey, you and me, I think we get along perfectly well. I don't like Zumba either. I'm not coordinated enough to do Zumba. I am a cyclist as well, and we're going to be riding closer to free again, this year as well. So that's always a great place to start. So, one of the things that I also wanted to touch upon quickly, Stacey, you were talking about this with the guidelines, right? And what's the right amount of exercise for what I should be doing? Stacey, what you were alluding to is these updated guidelines that came from the American College of Sports Medicine. And it's interesting to, again, to look back and see how far we've come, in just a short amount of time. When the American College of Sports Medicine came out with their exercise guidelines for cancer survivors in 2010, there wasn't a whole lot of research at that point to back up exercise for cancer survivors. And so those recommendations in 2010 were really based upon the general population. When they updated those guidelines in 2019, there was now this huge plethora of research studies that showed the benefits of exercise. So they were able to really, and it's really exciting for individuals like Kelly and I, who are the ones that are working with cancer survivors one-on-one, to say we can actually kind of dose our exercise interventions based on how people are presenting. So as Stacey was saying, for somebody who presents with cancer-related fatigue, with high levels of fatigue, if we want to do cardiovascular exercise 3 times a week, 30 minutes with strength training twice a week. Interestingly, now that we have more research out there, if somebody comes to us and one of their concerns is fear of recurrence, and they are presenting with higher levels of anxiety and depression, these new guidelines actually have a different dose of exercise for that. They actually recommend 30 to 60 minutes of cardiovascular exercise for somebody whose primary concern more is in anxiety and depression. So it's really, it gives us a lot of tools in our toolbox, so to speak. And so again, how do you start an exercise program? Again, Stacey was talking about this a little bit, finding what you like to do, and finding somebody that you can exercise with, whether that's in person or it's virtually, or you're texting your friend back and forth, you're keeping tabs on each other over various apps, to kind of motivate each other. I tell people all the time that it's always fun to have these little competitions to see who can get the most number of steps in over the month, or who can bike ride the most miles, and whoever then you got to meet up afterwards, and whoever didn't get that number of walks or steps then has to buy the other person ice cream or something like that, right? I think when we think about strength training, and I already saw the question pop up in the chat, how many minutes of strength training should our cancer survivors do? Strength training is not really about minutes. Strength training is more about targeting the muscle groups that can help you with your function and how to get you where you want to be. And I'll give you the perfect example. I'm working with an individual now who has gone through head and neck cancer treatment. He's had surgery and radiation therapy, and he's lost a lot of weight. He's lost a lot of muscle mass, and he was telling me that he's become so weak that he can't start his chainsaw. And his goal, the most important thing to him right now, is to be able to clear off land, on a plot of land that they have up on the Massachusetts coast, because he wants to build his retirement home and have that be a place for his grandkids to go. So that becomes a functional goal for us to say, okay, what muscle groups do we need to be approaching to address that this person's concerns? So we're working on core strengthening, we're working on shoulder stability, we're working on our leg strength and that sort of thing to make sure that we're able to do that. So when it comes to strength training, it's not really necessarily about minutes as much as it is about making sure that, again, that we're targeting those muscle groups that are really important for you. Again, when it comes to exercise and really being able to see your progress, I may be a little old school when I say, to write it down, to keep a journal, to kind of show your progress, but again, there are, if you have wearable technology or you have it on your phone, you can monitor this all on different apps. And it's really empowering to you, right? To say, okay, I'm starting a walking program. And the first week of June, I'm going to go out and I'm going to walk 10 minutes 3 times a week. Great. That's your starting point. And then the next week, you make that small achievable goal, like Stacey was saying. Now you want to walk 15 minutes 3 times a week. And then the next week, you want to walk 20 minutes 3 times a week. So by the end of the month, you can look back and you can say, look where I am now compared to where I was at the beginning of the month. And that's very empowering. And I think that's what we need to make sure that, we want to be able to help set you all up for success, so that really exercise becomes a lifestyle change. And I think you're going to hear that theme throughout this month with the different survivorship series that we're doing through Smilow this month, is that, so much of what we are discussing here through survivorship, whether it's exercise or whether it's nutrition or whether it's mindfulness, to really try to set up these patterns, these lifestyle patterns, to make these lifestyle changes to keep you healthy physically and emotionally for the balance of your life.
Thank you so much, Scott. And for those of you tuning in after the introductions, I want to welcome you. This is the Smilow Shares event talking about strength and exercise, and we have our panelists, and we will go into the question and answer portion of tonight. For those of you tuning in late, we have Dr. Janet Freedman, physical medicine and rehab doctor at Greenwich, Stacey LaRosa, nurse practitioner out of the Smilow Waterbury Care Center, Kelly Herzog, exercise physiologist, and someone who runs a cardiac pulmonary rehab program, as well as a breast cancer exercise program for survivors at the Greenwich Care Center, and Scott Capozza, a physical therapist in the multidisciplinary survivorship clinic in the greater New Haven area, and also an onc rehab specialist at Yale New Haven Hospital. I'm Tara Sanft, I'm your facilitator tonight. So maybe I'll just start by saying to Kelly, I think one of the myths is that in order to be in like a rehab program, you have to like look really weak, or you have to be really, debilitated. And I find that's a myth that I held, because I met survivors who had lobectomies for their lung cancer and they look great. But they said, you know what, I used to be able to walk from the train station to clinic, and this time I had to stop 5 times on the way. What do you like? Tell me a little bit about what you think about that myth and what you see in your patient population.
So we primarily see breast cancer patients at this point with our program, which I can talk about a little bit later. But I find that we've had the whole range of people. We've had triathletes, all the way through people who have never exercised. And we offer them cardiovascular exercise, where we do actually a submaximal stress test on their very first visit, so we can kind of see where their fitness level is in the beginning. And then at the end of our program, we'll do it again. And it's really exciting to see the changes. I have about 5 of them coming up in the next 2 weeks, thanks to Dr. Freedman. And I'm actually really excited to do all of them, because these women have really come a long way. So we just try to encourage them to get, like Stacey and Scott both mentioned, at least the 3 days a week of that cardiovascular exercise. And most of them are getting about the 3 days, not the recommendation of the 150 minutes a week. And then the strength training, we offer personal training sessions for them to learn what strength training exercises to do. Some have done strength training in the past, others have never ever done it. So we've designed a program for them. We meet with them 4 times. I write it down, they take it home, then we review in a couple of weeks. And we always, come up with a program based on, do they have equipment at home? Are they going to the gym? Are they going to use our equipment that we have at our facility? So with some people, I start with just very light band exercises and progress up to weights. I did that with someone actually just a few hours ago, and she said, oh, I think I can do this because I've already been doing it with the band, and that has helped me so much to know the motion. Now I can do it with weights. So we've progressed over these 3 months from a light band to weights that she has at home. So we just try to encourage to try to get as much movement as they can. And like Stacey said in the beginning with the fatigue, that really the exercise is going to help the fatigue more than hurt it.
Thank you so much. Dr. Freedman, I think this is a good time to start to address some of these questions coming through about lymphedema. Couple about blood draws. Maybe we could start with that one.
All right, so a little off our topic. Let me just say right now that a lot of the recommendations for people with lymphedema are really changing. They're really in flux. The European and Asian countries have a much more developed and sophisticated approach to lymphedema than we do here in North America. And similar to that long list of don't do, don't do, don't do, they look at us and go, what are you talking about? There's no evidence for any of this. So there's a lot of recent, very good research from all over the world that will also, just like now we can lift weights with lymphedema, we can draw blood from the arm with lymphedema, we can have blood pressure taken from the arm with lymphedema, because these things are not changing your anatomy. They're not a risk for developing lymphedema. And we do have a lot of really good studies. Now, right before the pandemic, I was at an international meeting and the US people said, okay, we're gonna have to sit down and rewrite all our guidelines because there's so much research out there. And then of course the pandemic hit and that has not happened. But I now tell my patients, you can have blood drawn from that arm. You can take blood pressure from that arm. If you have, are having surgery on the other arm and you need an IV, you can put that in your arm at risk for lymphedema, much better than putting it in your leg at risk for deep vein thrombosis. So a lot of these restrictions are really being lifted. So that will all be evolving soon.
These are major myths to bust. So thank you so much.
They are, yeah.
Stacey, maybe this is something you could speak to a little bit. What do you think a patient, right? What is it that causes fatigue years after treatment has ended? How would you broach that topic in your clinic? And I can also chime in too if you wanted me to.
Sure. So it's a good question. Unfortunately, the answer is not always 100% clear. Oftentimes it's multifactorial. So for instance, for some patients, so it depends what you consider treatment ending. So some of our patients have chronic lymphoma, for instance, and they might be on treatment and then off treatment, but maybe they're anemic chronically. So they might chronically have a low level of fatigue related to that. Certainly emotionally, depression and anxiety, like Scott talked about, can contribute to fatigue as well. That's a huge reason people complain of fatigue. Immediately after treatment, certainly there's some cell repair that's going on that can make you feel a little bit more fatigued. Some people have trouble sleeping, with whether that's just regular run-of-the-mill insomnia or if it's related to anxiety about disease recurrence. Any of those things can cause insomnia, also cause you to feel fatigued. So there's a lot of different reasons that can cause you to feel fatigued even years after you're done with treatment. And unfortunately, it's not always easy to pin down.
I think that's exactly right. And, sometimes you can have other medical issues that come up that can mask as fatigue or be signal. Fatigue can be a signal that something's wrong. So there's often a bunch of labs that people might do just to rule out any other issues going on, in addition to all the things that Stacey mentioned. Okay, Scott, let's hear from you. There's a couple questions. One is about the updated guidelines. So maybe you could speak that. I see you put something in the chat. And then there's also a question for women with metastatic breast cancer to the bones. Is it okay to do weight-bearing exercises?
Mm-hmm. Yeah, I just tried to pop the American College of Sports Medicine guidelines into the chat. If it didn't go through, somebody let me know and I'll try to repost it there. So to the question about anybody with metastatic disease, anybody who may have bone metastases, the answer is yes, that you can exercise. Again, for anybody who has metastatic disease, we would highly recommend that you would work with a physical therapist or work with a certified exercise physiologist. to start a safe program. My approach to this is to do a lot of what we call kind of closed chain exercises, at least starting there. And what I mean by closed chain exercises is that to make sure that the hand is anchored or that the foot is anchored. So I might start with like wall push-ups, for example, and something like even like squats, for example, is a safe exercise. And we can even, like, if you're in our gym, we can set the height of the mat table, for example. So instead of going from a very low height, we can raise that height so that it's just a very small distance that you have to do that's to stand to do that squat, so to speak. And so we would start there, and then we would progress you through slowly and safely. But yes, we would be able to progress you through that. And it's interesting. The American College of Sports Medicine, they just had their big annual conference last week, all virtually, and there was a great talk about exercising. And so supposedly by the end of this year, by the end of 2021, they are going to update their clinical practice guidelines for exercising for individuals who have bony metastases. And so we'll definitely have a much clearer picture. And so for all of us as the clinicians, we're going to be able to take that and bring that to you. But I am currently working with people who have bone metastases now. And again, that's my approach. Yes, I want you doing cardiovascular exercise safely. I want you doing weight-bearing exercises, like I said, typically starting with closed chain exercises, and then we can progress from there. I did see somewhere in there too, maybe this also kind of corresponds. I saw a question about crunches. And so this would be another opportunity for education, that Kelly or I could do, to say, okay, maybe we don't want you to necessarily do crunches, but there are other core exercises that you can be doing that can engage your abdominal exercises and work on that core strengthening, but protecting your back at the same time.
Okay, thank you. All right, so here I'm going to read this chat and see, maybe Kelly, this might be appropriate for you, but anyone can chime in. What would be considered too much exercise? For example, is there a maximum heart rate, I'm 42, that we need to stay under? When I first got diagnosed, I was only walking about 2 miles per week. I couldn't keep my heart under 130 beats per minute. Now I can walk 4 to 5 miles 5 times a week. Great, without going over 120. I recently had my power port removed and I have started with weight exercises, but my heart rate often goes up to 150 range. Energy hasn't been a problem, but I'm concerned about injuries and setbacks. Thank you. Thanks for that question.
Can you just read one more time when it goes up to the 150 range?
Sounds like with a new straight weight exercises. So I think that's strength training.
Okay. So I'm wondering, so first of all, that sounds like great fitness progression from the beginning part of that question. And we tend to see, when I first do that submaximal stress test with people, I tend to see heart rates skyrocket in people that you would see if they walked through the door, look very healthy and fit to you. I see them going from a resting heart rate of 80 to 140 within the first 3 minutes of that submax stress test. So I see that a lot. I think the deconditioning from the treatment really does a lot, but that progression sounds good. With the strength training, getting that heart rate up to 150, I'm wondering if maybe there's some breath holding going on there, or the exercise maybe is a little too hard. At 42 years old, you should be able to get your heart rate up to 150 if you're not on any cardiac medications, I would say. We typically do a Carbonin calculation, which once I'm done talking, I can even figure that out, but I don't know this person that well in any other meds, because we also use that submaximal stress test because it's so very individual, to see what heart rate that they got to, what's their 85%, if they even reached it. Some people aren't even physically fit enough. But the walking in this question sounds sounds great, but I'm wondering maybe the weight is a bit too heavy to start out with, and maybe the breathing, exhaling on the exertion, paying close attention to the breathing, not holding breath and breathing properly. And also possibly maybe they're doing, is she doing he or she doing multi-muscle strength training? Is when you're doing both upper body and lower body at the same time, you might be hitting higher heart rates. So that would be kind of my thoughts for that question. I hope it helped. If you want me to figure out a Carbone, I can, but again, not knowing this person,
I think those are some great thoughts to start with, for sure.
Okay.
Here's another one that maybe piggybacks onto this with strength training. How can I do strength training without bulking up my muscles?
That's a good question. I can start with that, and then Kelly, if you want to hop in on that one too. So if you want to build strength without building a lot of bulk, typically what we would tell you is to do kind of a lower weight but higher repetitions. And so again, Kelly, you were talking about the bands, for example, like all of these resistance bands that we use in the exercise classes and in therapy, they're actually all color coded by resistance. And so you can use one of the bands that has a lower resistance, but rather than doing 3 sets of 10 repetitions, maybe you're doing 2 sets of 20, but it's a lower resistance.
So you're saying you can strength train without getting huge, big muscles?
Mm-hmm. Yep, absolutely.
And I can just add, if it's okay, I can just add a little bit to that. I also find that it's actually kind of hard to get huge, big muscles. You have to be working in the gym very regularly, lifting very heavy weights, but also there's the nutrition side of things that people that get huge, big muscles tend to be trying to eat a lot of protein. Maybe they're taking protein powder, they're eating a lot of calories. It takes work to get huge, big muscles. Also, a lot of that is genetic. Some people can get bigger muscles easier than other people, even if those people are trying. So like Scott mentioned, the lighter weight, we tend to do 2 to 3 sets of like 12 to 15 repetitions, but I don't really have people doing heavier weights with the lower repetitions to build the muscle. So I think it's difficult to grow big muscles.
A lot of women don't want big muscles, so that's probably reassuring.
But it's hard. It would be hard to get big muscles.
Well, Stacey and Janet, I know, so Kelly mentioned a little bit about people who are bulking up and eating different things. What do you guys talk to your patients about in regards to diet and exercise? So someone wrote, if I exercise, should I change anything that I eat? Should I be eating more protein? Any thoughts on that?
I think it depends. If, like Kelly said, if you're trying to build muscle, certainly protein is important, but I think speaking with a nutritionist can help in terms of determining exactly how much protein you need, and if you don't necessarily need to bulk up. So I think talking to them about that, and I always tell patients it's not really about a diet per se, it's just about a well-balanced eating and lifestyle in terms of, I feel like diet sets you up for failure in terms of doing it for a short period of time and then falling off the wagon versus making lifestyle choices both before and during your cancer treatment and after.
I like that. How about the pattern, right? And we are going to have a session in 2 Tuesdays on supplements and nutrition after cancer. So stay tuned if you have more questions about that. Okay, let's see here. There have been some really interesting questions coming in. Janet or Kelly, I am 6 years post left pneumonectomy. I still need oxygen drain exertion, walking, stair climbing, etc. Otherwise, I desat rapidly. Should I be concerned? Any thoughts on that? You guys have much, I know Kelly, I had heard you had done pulmonary rehab in the past, but maybe I'm putting you on the spot for this question.
No, that's okay. Most of the patients I do pulmonary rehab with are COPD or interstitial lung disease, not as many lung cancer. But, you know, is this person exercising regularly in order to condition the heart and the lungs and the muscles? Have they had pulmonary function tests to see if there's something else going on requiring them to need oxygen while doing these activities? Would be my thoughts on that one.
Yeah, I would agree with that. I think that if the person has not had any formal exercise type of instruction or therapy, that would be helpful. I think a lot of people feel if they're getting short of breath with exertion, the solution is not to exert themselves, as opposed to the understanding that endurance exercise will increase their tolerance to activity, both by working on their heart, their lung, but also helping their muscles be more efficient with the oxygen that they're getting.
Thank you. Here's a good one. I bet, Scott, you could probably talk about this. I'm almost 5 years cancer-free. I have a great deal of radiation damage after stage 3 breast and a double radical mastectomy. There's a hardening and stiffening, which is quite painful. Do I work through the pain or possibly look towards an additional surgery to help? Anything upper body at the gym or even lifting to put dishes away hurts. Everything pulls.
Yeah,
I hear
that's,
this all the time in my clinic,
yeah,
and I
yeah.
send them
And
to you.
yes, yes, you do, Dr. Sanft, and I'm grateful for that. For this first person who wrote this question, and first and foremost, I want you to know that you're not alone. What you're experiencing sounds like something that we call radiation fibrosis syndrome, which is kind of this long-term side effect that we see. Is that it's this kind of gradual binding down of the connective tissue, not necessarily the skin, but like that layer of connective tissue that's just below the level of the skin. And everything that you described is, you're right, everything just feels tight and you just feel like you can't move that arm over your head. And what I would say to you is that we don't necessarily want you to push through the pain, because obviously it's not comfortable. You would want to get a referral from your oncology team to either a physical therapist or an occupational therapist, because we can do a lot of manual therapy and actually get our hands on you to try to work some of that scar tissue out of there and to try to loosen that connective tissue first. And that's a lot of what I see in my outpatient clinic. I have to address those musculoskeletal impairments first before we can address strength training. You can't go through a really good strength training program if your range of motion is limited and it's painful. So we'll address that part first. The other thing that we see, and again, Dr. Sanft, I know you see this, and Dr. Freedman, I know you see this. Is if somebody develops a condition called cording, where sometimes you get that tight band kind of right here, and so same thing. It's hard to raise your arm and it's painful, and so we as trained physical and occupational therapists, we can go in there and use our hands to help loosen that up. And there are some modalities that we can use to assist us with that. And then once that gets loosened up and you get this range of motion, okay, great. Now that's kind of been freed up, now we can move ahead and we can do the next phase of things, which is the strength training.
Yes, thank you so much, Scott. There's so many good questions here. And I know we're coming up on the hour soon. Maybe what we could do is talk a little bit about these issues that affect the hands and the feet. So I'll read the neuropathy one, and then I'm also going to piggyback that into the hand-foot syndrome one. And so any of you who feel like you can comment on this, please hop in here. But here is what one listener wrote. Neuropathy in my feet impairs my ability to balance and walk safely. I'm 74 and have severe bursitis and tendonitis, which developed after COVID ended aquatic therapy prescribed at Smilow. I have had PT for this since last August. It developed when I tried to do normal gardening and landscaping work. Everyone, PT and orthopedic doctor, says pool only. How does that square with recommendations for cardio and resistance recommendations? And then the piggyback to that is suggestions for exercise with hand and foot syndrome due to Zolota. I know they're two different things, but we have a lot of questions, so hopefully just trying to get as many people's questions answered.
Well, I'll start, and then I don't know, Dr. Freeman, if you want to jump in on that. You know, from the you're right. You know, we did send a lot of people to aquatic therapy when that was an option, and I know that is not an option for a lot of people now. As far as the neuropathy goes, you know, my approach has been, you know, kind of a multi-pronged approach to neuropathy. You have to address the sensory aspect of things. You have to work on the strengthening aspect of things, and you have to work on the balance. And so, what a typical session with somebody that I'm working with who has neuropathy, and I probably had 3 or 4 individuals just today alone that this is what we were working on. I have them take their shoes off, and we get on an uneven surface, and we're practicing sit to stands on that to work on leg strength. We have a small vibratory device at our clinic that we'll use that vibratory device to try to help stimulate, give that deep pressure sensation to the toes and to the bottom of the feet to try to help with that sensation there. I know our occupational therapy colleagues have a lot of training when it comes to sensory reintegration, and so I'll tap into them a lot for their thoughts as well. And again, a lot of hip strengthening, core strengthening. You're right. We want to make sure that we're preventing any increased risk of falls when you can't feel your feet. And then as far as like the bursitis go, like, you know, those we can address, you know, with kind of like our classic physical therapy interventions with, you know, with modalities, with ice and heat and those kinds of things. But when it comes to neuropathy, you know, it's not just one treatment modality that we're going to have to use. We're going to have to use a lot of different tools in our toolbox, so to speak, to be able to address that.
Thank you. Okay, let's see here. There's one specific. This question is for Kelly. If we are interested in beginning an exercise program after treatment, how can we get an appointment with you if we weren't initially treated in Greenwich? Thank you. This is really interesting. I have a fan.
So Dr. Freedman can probably help me with this a little. So originally the program started out, I've been at Greenwich 15 years, and there was a grant provided for breast cancer patients for our 3-month free program to breast cancer patients who have had their treatment at Greenwich Hospital. And it encompasses the cardiovascular exercise, the personal training sessions, as well as nutrition counseling. So there is no more grant, but the hospital administration has wanted to keep it going because it's such a great program. So what normally happens is the patient sees Dr. Freedman usually, and sometimes our other physiatrist, Dr. Grant, prior to coming in order to rule out any of those issues that Scott was talking about earlier with, you know, the cording or the, I forget the name of it. Was it the radiation? Fibrosis? Yes. Anything like that, any musculoskeletal issue that needs PT or OT first, Dr. Freedman will see them, and then she'll refer them on to me. You know, this person is going to be ready after PT on May 29th or whatever it may be. So that's typically how it works. It's a gift. It's a free 3-month gift. Now, as far as not being treated at Greenwich Hospital, that would be something that I think we at the hospital could talk to our director of the program about how, you know, he wants to go about it, whether they're treated somewhere in the Yale system, if that's okay, because at this point, that program is breast cancer only, and it's a 3-month gift. But we can see a patient who has cancer. We have a medical fitness program, and the person just does have to pay out of pocket a fee, and then we can still do all of the tests and work you through a program for exercise. And we have people, you know, that have come in and done that. Not quite as many as in the breast cancer program, but we do get some. Does that help at all?
Yes, thank you. And, Stacey, maybe you can chime in here too, because there had been a question in the chat about exercise places that are free or low cost. And so I'm hearing that there are some resources at Greenwich. Of course, anyone needing physical therapy or occupational therapy should ask for a referral from your oncologist. We also have a multidisciplinary clinic where you could get a medical type visit with some exercise information embedded in there with Scott Capozza. But Stacey, tell us a little bit about what you tell your patients out in Waterbury when they ask about low cost programs.
So most often we refer to the Live Strong program. I think you can actually find those across the state in most YMCAs. A lot of them shut down during COVID, unfortunately. But I think the one in Waterbury I'd heard recently was starting to open back up. Heard a patient about that, mention that recently. So that's exciting for people to be able to get back in there and work with someone who actually knows what they're talking about and can teach you how to safely exercise and kind of get back into things. Obviously taking into mind safety first. So asking your medical provider who knows your medical history first, whether or not that's safe or recommended. Scott had also recently introduced me to a program run by the Quinnipiac University students, which is virtual, and he could definitely speak more about that. It sounded really interesting. So.
You want to say something about that, Scott?
Yeah, there's a group of physical therapy students at Quinnipiac University. If I can find the flyer, I will try again to try to post it into the chat here. They are offering a virtual exercise class for any cancer survivor that'll be starting later this summer. And so it'll be run by the students, but it's supervised by me and their professors. So we're pretty excited to offer that to any survivor in the state.
Wow, what a great program. And we should just clarify that we define any survivor as having had a history of cancer, starting from diagnosis through the balance of your life. And that had been a question in the chat before. Here's one last, we have about 2 minutes left before we'll start closing here, but I am a 71-year-old into my 5th year of prostate cancer survival. My testosterone level has been below normal, and I had a compression fracture at the T5 or 7 level of my spine this past January. I have no pain emanating from the fracture. Should I forget about strength training? I swim or walk 6 or 7 days per week, which sounds great. Anybody have any thoughts on this gentleman with a history of a compression fracture?
I think as Scott said earlier, these people with any type of bone mets certainly can exercise. They just need to be doing it to begin with under supervision and gradually increase. And certainly there's not, I don't believe, a reason not to resume other exercise. Aquatic exercise is great. It does not give you any gravity really, so you're not strengthening bones, but you certainly can do a lot. You can do a lot of strengthening in the water with the styrofoam noodles and things like that to give you some resistance. But then you can also begin a supervised strengthening program on land.
Great, thank you. Okay, and then let me go up because there had been a kind of an initial one, and maybe Kelly, you can comment on this. I'm 59 now, but was diagnosed with mantle cell lymphoma in late 2018 after localized radiation in 2019 and then 6 months of chemotherapy in 2020 with good results. Unfortunately, I sadly contracted COVID-19 and symptoms lingered for 6 months and led to interstitial lung disease. Sorry to read this. Putting aside the COVID component for a moment, for those of us still competing in an aerobic sport, running, cycling, rowing, is it reasonable to expect the body to recover back to the same level as prior to treatments? If so, what is the reasonable time frame to set on those expectations? So this writer had not only lymphoma, radiation, chemotherapy, also then COVID and some lung consequences from that. So Kelly, with your vast experience, there's a lot there. How do you unpack some of this? What should this person expect?
You know, timeline I think would be pretty hard for me to say at this point. We have a couple of people right now post-COVID that were both in the hospital a long time. One of them does wear oxygen. The other one does not, but she was desaturating in the beginning, and now she's doing better. We've had them for several months now, and they're still working themselves back up. I think it's going to take a lot of time. Unfortunately, I don't know how much time, I'll be honest with you, especially given, unfortunately, the cancer diagnosis and treatment prior to the COVID diagnosis. But I think you said the age was 59, right? So I think that you have age on your side, that you're able to, and you were an exerciser prior. And that's also very helpful because your body doesn't forget that you have exercised before. So I think if you just continually are doing moderate exercise and in a monitored setting or a supervised setting where you're watching your heart rate and your oxygen saturations, that would be beneficial for you, because then you know, and just continually, just as regular as you can make the exercise. If you can get there the 3 days a week, or even if you're able to do 4 to 5 days a week, I think you will be able to get back to it, but timeline, unfortunately, I don't know. I don't know if Scott or anyone else can speak to that.
That's a really hard case. And I think someone like that, I hope can, seek out some supervised help and try to get back to the goals that you have for yourself. And thank you so much for taking the time to write that. Okay, we have 2 minutes left. There's some questions about how people can reach you, those of you who are actively prescribing exercise programs. Maybe what we could do is just say how you guys stay healthy in the midst of a pandemic and also seeing patients, if you exercise at all, if you care to share, and then we'll close out this last minute here. How about Janet?
Well, I had the benefit of working in the hospital in the pandemic as a pharmacy runner, and I walked about 5 to 6 miles a day in Greenwich Hospital. So that really helped. But like many of my patients, I started to develop foot and knee pain from suddenly having walking as my only exercise. My gym was closed. I don't really have much at home. So I learned a lesson from that, and actually have seen a lot of people who said, oh, I was walking 6 miles a day and my feet are killing me, right? But I've gradually returned back to the gym as I've been brave enough to go there. So that's what I'm in the gym with a mask on.
Thank you. Stacey.
So I love to bike, like I said. I actually joined the cult following of Peloton during the pandemic. So I have to say that that's my ideal way of working out, particularly with a 4-month-old and a 2.5-year-old at home. So that's my go-to.
Love that. Thank you. Kelly.
During the pandemic, I was also redeployed to the hospital, but unlike Dr. Freedman, I was redeployed to a completely sedentary job in front of the computer all day, which gave me migraines and made me cry when I went home. But my hours were 8 to 4 or 8:30 even, which are much later than my normal work hours. So I was able to get up in the morning and walk the neighborhood or do yoga or something prior to that sedentary day. Also, almost every hour, I would just go down to the bottom level of Greenwich Hospital and up to the 3rd floor on the stairs before returning back to the computer to try to do some sort of movement. And now I'm kind of back to my normal, walking, and I've gone to the gym as well, like Dr. Friedman. And I have 3 young kids too. So I'm, playing wiffle ball and whatever we can do to stay active.
Oh, thank you, Kelly. And Scott.
Yeah, so interesting, Kelly. I was the opposite when I was redeployed last spring. I was doing inpatient care, and so my hours shifted to 7 to 3:30, and so I was getting home at 4. And so so instead of getting home later, I was home early. And so the kids and I would actually go biking around the neighborhoods. And so that's how we got our Closer to Free training in last year, was taking the kids around the neighborhood, after being inside all day. And they were inside all day on their screens, doing the virtual learning. So they needed to get out and exercise as well. And so you're hearing a common theme here with, trying to exercise with little kids. A lot of it is, kind of picking your spots. I mean, I will drop my daughter off for soccer practice, and then I will go for a run, and then I will pick her up when she's done, because that's the only time that I've got. And so you learn how to find these little holes in your schedule. You learn to get creative. Or the other thing, Dr. Sanft and I know you and I, we need to start getting on the bike and start our training. So again, you use the buddy system and you motivate each other, and you say, all right, I will be at your house at 7 a.m. on Sunday morning. Let's go. That's
right. Well, it's 3 minutes past the hour. For contact information, further questions, please feel free to email us at canceranswers@yale.edu. Otherwise, we'll see you back here next week, where we're talking about sexuality, intimacy, and menopause symptoms after cancer. And thank you for our panelists and your time tonight. I think this was really successful, and we couldn't have done it without all of you. So thank you very much. Good night, everyone.
Good night.